Welcome to another segment of HR the Leader, where we are here to talk about leadership, to talk about respiratory therapy, to talk about healthcare. Most of us on today's platform, we all of respiratory background. So everybody knows Carrie. She's not a stranger to the podcast. So I'll let her introduce herself second. So for the first time on the podcast, we have John Fisher with us. I'll let John introduce himself. I would do ladies first, but Carrie didn't know what you bring. You are a friend of the podcast. So we'll let John, our first time guest, introduce himself. Then we'll let you introduce yourself. For those who don't know you, definitely you're a friend of the podcast. You've been here a long time. That's your third time coming to the podcast. So I'm
Yeah,
well work
it
to
is.
making you a co-host very soon. We'll talk offline about that. So John, tell the people a little bit about you, and then we'll get this thing going.
Perfect. Thank you for thanks for the brief intro. But John Fisher, registered respiratory therapist, EMT background as well. Been from a bedside clinician standpoint, RT for going on 14 total years, and in multiple different capacities, from clinical educator to air and ground transport as well. Different capacities and different roles within the respiratory community. So excited to be here. I've definitely been a follower of some of your other previous episodes where, of course, yes, I've seen Carrie in a few of those. So I'm definitely excited to be a part of this, and look forward to the conversation today.
Thanks, Carrie. Friend, tell them about you.
Yes.
For those who don't know you yet.
Right. So, Carrie McClure, I'm currently a clinical supervisor at a smaller hospital in the metro Atlanta area. I've been a registered respiratory therapist since 2013. I have a bachelor's degree in respiratory care, and now I have an MBA. And that's pretty much it. So, most of you know me.
Try not to get me canceled again today.
I
We're
will
good.
try not to get you canceled. Yeah.
And I know you and John it's a very deadly combination. Both you guys, please do not get
Yeah,
me canceled. All
yeah.
right.
Maybe we'll
We won't.
but we
All right.
like balance each other out. Maybe so. Yeah,
Mm,
Or
all
make it
right.
way worse. It'll go
We'll
either way.
try.
yeah.
Yeah.
So this conversation is gonna be interesting. Volume based versus value based, more patient or better outcome. I'm gonna start with my experience. When I got into leadership, I did not know, we didn't have this conversation. My predecessor, the person who onboarded me, we did not have this conversation onto what metrics I need to look for success. So they literally showed me this is the key. They give me a crash course, drive, get results, but I'm not knowing what was important. So for decades, healthcare has largely operated under volume-based model where
Uh-huh.
more patient, more procedures, and services often translate into greater reimbursement. Today,
Yes.
the landscape is changing. Healthcare organizations are increasingly being evaluated on outcomes, quality, patient experience, safety, and cost of effectiveness. The shift towards value based is transforming how success is measured across the industry. Worst case now, if somebody just got into leadership within the next 2 to 3 years, they don't even know where they're coming from, what they need to
Mhm.
transition out of. And we just out here leading, taking care of the people. But most of us don't know how to achieve the metrics or organization are putting in our plate. So this conversation is great. We need to have it. For the longest, we know the work unit tool. We've talked about the RVUs. We've had a lot of staffing model from our different organizations, but I have yet to see or witness that conversation within a respiratory volume based versus value based. So today we need to have that conversation. So let's just talk about it. If y'all want to define it, let's talk about volume based first. What is it, and what metrics you think is important when we're talking about volume based care?
Well, I think definitely procedures, treatments, um, productivity, I don't know, labor costs.
Hmm.
Jump in here, John. You know as many as I do. What like units of service? I'm trying to like go through and think. I mean, I think when it comes to volume, those are the big ones that I think we are currently measured by
But
So,
in volume.
yeah.
that's the only thing we've been measured out, right? Because everything now you talk about, if you call, I'll, let's put a bet. Let's call the next 10 leaders. I'll call the first 10. You call the second 10. We all
Hmm.
call 10 leaders. This is the metric how 90% of us run a department.
Hmm.
Mhm.
Everything you just mentioned, that is exactly what leaders out there are chasing, and hospitals are putting on our metrics to attain. This is what success looks like: treatments, procedures, productivity, staffing ratios, billable service. This is it. So
So
what are we missing?
volume based healthcare essentially is isolated down to saying the success is measured based off of how busy you can show your department is, not how operationally efficient your department is, right? So, I mean, I would like to ask an answer here. Um, Historically, that method would say that if your RT department got double the amount of treatments today that you had yesterday, does that mean that your department is twice as successful today as they were yesterday? No, right? So the shift from volume to value is saying it's not that you're twice as successful by having double the treatments. It's maybe we're getting now to the point of saying instead of measuring treatments, it's how many admissions did we avoid today? How many
Yes.
readmissions did we impact? How did RTs directly impact throughput of the emergency department and doctor disposition time? These are going to be the things that are going to steer us in the direction to where respiratory, in my opinion, truly in 2026 finally has the opportunity to not just be a seat at the table, but to dominate it. And I think one of the things that I think can maybe help the listener say, well, why are we just now starting to have this conversation? So you're telling me it's new in 2026 and now we're just having a boom, snap our fingers and start with this new vision. That's not necessarily true. This has been going on for about 10 years. But the problem is that none
Hmm.
of us as respiratory therapists have a job title that ends with an O in it. There's CEOs, there's CFOs, there's COOs, and what else does there? There's CNOs, right? So chief nursing officers have been driving this for almost a decade. I would say outside of the field of nursing, probably the other allied health bedside provider that's been influential in the value based model is physical therapy. How fast can you get patients post operatively up? Right? How fast can we get patients up and moving and more ambulatory? And then how fast can we get patients discharged from post operative orthopedic surgeries? So now, if that all that to say, here's the respiratory therapist opportunities for the RTs that are listening here. This is where I want you guys to open your ears and to look at this as an opportunity. COPD, for instance, is the number one cause of ED admissions in the country. It's the number two cause of hospital length of stay and throughput bottlenecking. You're the number one cause of hospital readmissions out of all your chronic major diseases. So ask yourself this when you look at CMS's guidelines of what they care about when it comes to your metric performance of your hospital, how is it when you're the number one, the number two, and the number one of the patient population that we impact? How do we not only have a seat at this table, but we should be dominating this conversation in the ROI capacity of your hospitals that you work with? That's the opportunity that respiratory has. Value based healthcare finally makes us not a cost center, but an ROI generator.
Amen. Yes, exactly.
All right, let's pause, right? Let's not go to the master class because right now this was the master class answer.
Yes.
And now that I'm all around that and I've done a lot of homework and try to understand the landscape, this is gonna be on YouTube. This is gonna be streamlined from different landscape and point of view. A lot that you just shared is probably gonna go above a lot of a leaders' comprehension. And here's the truth about that. And this is not going to be for new leaders. You're probably going to have leaders been in the field for over 15, 20 years that cannot understand the transition of going to a value base. So you talked about throughput, you're talking about length of stay, you're talking about all those key terms that now is not volume based, but more so of a value. What do we need to do as respiratory therapy leaders to help us change that mindset? Because at the end of the day, we still have to think about the number of vents we are getting, that we still have to balance the volume that we get and to translate that into the value output that we need to produce. Can you break everything you just said down a little bit to a healthcare leader RT 101? Because that was a master class. Break that down to a 101 level.
Well, I
You
mean,
have,
I think,
yeah,
I honestly feel like we have to evolve our thinking. That's going to have to be the first step because patients do not experience productivity, they experience outcomes.
Say that
And
again. Say it again. Say it again.
patients do not experience productivity, they experience outcomes. That's the mistake we're currently making is that we are so task focused that we have lost sight of the outcome. And that's what matters at the end of the day is did we what how did we change this patient's trajectory in the hospital? Every therapist that has a patient, that needs to be what they go in asking from the start. How am I going to change this patient's trajectory today to get them where they need to go? So I think that mindset shift is going to be essential in understanding the difference between how we've done things previously and the direction we need to go. And we also need to evolve as a professional association. I think that, we have a lot of work to do at the association, the AARC level, in getting us heading in this direction. What are your thoughts, John? What were you about to say?
no, I think, but I mean, so the thing is about this is like, Hans, one of the things that you mentioned is that it's going to be over a lot of directors and leaders is way of thinking that are starting, especially earlier on. Doctors like, I would challenge it a little bit, right, and say no one went into healthcare that didn't care, right? I don't think that
Right.
anyone's going to go through respiratory school. I don't think anybody's going to go through nursing school. I don't think anybody's going to go through the stuff that we've all been through and getting our boards and things taken care of that doesn't care, right? And I think what this is doing is it's sadly to say it's just now where you're being rewarded to care. And historically,
Yes.
maybe because volume based has been so much of get as much done as possible today to justify your job and your belonging because we just need y'all to be busy. That's it. We just need you to be busy. Just go do things. Where it's kind of like I would even say that some of the toxic cultures that we see in unfortunately in the community that respiratory students are some of the most brightest and eager ones to learn, and some of the most go-getters coming out of school. And then over time you kind of see that go away. You kind of see that fade away. And I think that that is another thing that maybe potentially is an opportunity for us as a society here, is to say, look, man, when you start really reeling yourself back and saying, let's just take all of ourselves back to where we were when we got out of school, and saying, look, you have an opportunity to change a life. You have an opportunity to change an outcome. You have an opportunity to impact a human being. And if that means that you're not doing 55, instead you're doing 20 of the same thing today, but you're increasing the quality in which what how you're doing that job, I think value based finally brings the opportunity for those people to be rewarded for good outcomes, not just how much of it you got done. I think we all care,
Well, I
and
think
value based
you
is just
could
bringing that.
take you could do, 80 treatments a week. I mean, just easy number. And, and track the outcomes of those 80 treatments, and then track the outcomes of 40 treatments and see if you impacted anything. I think measuring the difference, how you are, because we all know that like therapies and procedures and tasks don't necessarily equate value to a patient. Sometimes it's just more, and more is not better. Oftentimes more adds to all of the things that hospitals are trying to prevent. So, what we have to do is show, okay, we did the right thing at the right time for this patient and the outcome was better. We're not going to be able to get away from metrics. We're always going to have metrics. And I think that if you know, we would be fooling ourselves to say that metrics don't matter. We have to have those, but the kind of metrics that we have and what those metrics mean
Yep.
is going to have to change.
Yeah, and what we're capturing,
So
right? I mean, yeah, that's
Yes,
I think, and I think dashboards is where a lot of that comes into play, right? Right now, your dashboard
absolutely.
is probably showing how busy your department is, not how productive your department is,
Yeah.
right? Not the outcome that is a result of your department. And I mean, I think that that right there summarizes what we're trying to achieve. And
Hope you're enjoying the conversation so far. At HR The Leader, our mission is simple: building leaders, transforming organizations, igniting purpose. If you'd like to explore more leadership insights and resources, visit www.hrtheleader.com. And if this conversation is bringing value to you, take a moment to like the video, leave a comment, and subscribe to the channel. Your support helps this platform continue to grow. Now, let's get back to the conversation.
look, I don't care how busy you are. I care about the quality that your department is contributing to. Um, you know, uh, we not just the respiratory care today, but tomorrow, as we're seeing, RT opportunities are not excluded from opportunities to be removed, right? I think we've all seen the Mayo discussions that have been going around. These are the
Yes.
opportunities to show, look, you're going to learn after these RTs go bye bye what the downstream effect of not having us is, unfortunately. But I think when we show our value day in and day out, we're painting that picture without having to compromise anything.
Well, and I think therapists are feeling beaten down because they come in to the department every day absolutely exhausted, but have they created value in that exhaustion? So, I think they've lost their sense of purpose. And, going back
Mhm,
to culture, what you were saying a few minutes ago, John, like I think that is a contributing factor to some of
mhm.
that light and enthusiasm burning out because they just, it's like they're running with, backpacks full of rocks. And, we need to take some of the rocks out of the backpack and let them work effectively and see what they're able to do. And I
Yep.
think that will go a long way to changing that culture.
Here's a question. Most leaders in our fields, in our department, a lot of us have been promoted from clinical to leadership.
Hmm.
And there's a portion of that where 90% of us still lead from a clinical standpoint.
Yes.
How important it is to help us make that transition from volume to value. How important you think it is for us to understand CMS reimbursement, to actually understand what create value and what is busy work versus productive work. Because as you could actually see, respiratory therapy in the past, having a heavy assignment was a badge of honor.
Yeah.
Hmm.
Leaving the
Yeah.
hospital said, "Man, I had 10 vent, I extubated 4 and I admitted 6," and then, when you left like the Avengers that you conquered the world, you did
Yeah.
everything else. And those are the people now who are in leadership, who
Yes.
still can understand what we are talking about. So how important it is for leaders to actually understand the healthcare shift as far as reimbursement and as far as seeing RT as a continuum, not RT as a silo.
I think it's extremely important. And I also think to a degree, the therapists at the bedside need to understand as well, because they need to understand what direction they need to go in and why they need to move a certain way with a patient. I mean, you always have good thoughts on this, John. What are your thoughts on this? I feel like it's extremely important.
Yeah, I mean, I'll kind of relate this back to my old transport backgrounds, right? I would feel super pumped if somebody was like, "How'd your shift go?" And I'm like, "Dude, we had a fixed wing flight today. We did a rotor wing and 5 ground transports. Well, we were just hopping and popping. We were busy." But no one ever asked me, "So how'd those patients do?" Right? No one ever asked me that.
Exactly.
They were just like, "I heard you got 4 intubations today." I was like, "I sure did." All right. No one ever was like, "So what was the blood gas that you got when you got back to the hospital? How would you ventilate them on the way between point A to point B?" Right. And I could even say at the time at the bedside, right? It's like, man, I had yellow and red pod in the PICU, and I was overflow for the ED, and it's like, man, this dude is just all over the place. But it's like, how well did your patients do? How many patients are those that were teed up ready for extubation by day shift rolling around? Like, those are the things that, are in the ER. Like, man, I did 5 continuouses a day. Well, how many patients did you get discharged? Like, it's a different level to measure. I would argue to say that it's the
Yeah.
same thing. Hans, you bring up a great point. These superstars that we're talking about, we've all been in these conversations, but now we're adding one extra
Hmm.
question to the end of that. It's like, look, you've taken care of a whole bunch, but what was the outcome, right? What happened as a
Yep.
result of that work? And honestly, I think that what this does too is it goes and says, okay, well, maybe our future rock stars of respiratory care aren't those that have done 99% of the work. Instead, it's those who can say, you might have done double the treatments of me, but I got 20% my patients discharged, or I contributed to a 3% reduction in avoidable admissions tonight, right? That's the future direction of where value based healthcare finally brings value to outcomes.
Here's the other question, though, that all of us are afraid of asking. And I think the leaders who are actually watching and listening to this was like, well, this is great. Staffing. Um, it boils down to that. So, in my mind, to create better quality and, and improve the quality that we do and get the outcomes, we have to change our staffing ratios. Um, how do we even consider there's a leader right now say, "Hey, I like this, but this is what I have to deal with." And again, values sometimes does not translate into FCE. And Kerry talks about this on LinkedIn a whole lot. Um,
Hmm.
as to and actually, when we do it right, we decrease the FTEs. Let's just think about it, right? If
Yes.
we could
Yeah,
decrease
it's a balance for
vent
sure.
days,
Yeah.
if the goal is to get them discharged, I mean, I need to decrease vent days. So now I'm running a lower number of vents. Because now I'm getting them extubated, I'm getting them through on the floor, and we have there's no more bottlenecking and everything else. So now we have a good patient flow. Now let's go back to this is where volume, where we're gonna say, well, a few more treatments, but my ICU is carrying my productivity. So we still need a little bit of it's a delicate, it's a very delicate place to be. So
Well,
how do we switch, and how do we help them switch?
so I think we need to be asking, not how, what all can we do on a shift, but now the question becomes how much organizational risk can we prevent?
Well,
Because,
organization.
you
Yeah.
know,
Yeah.
because then we become readiness based. So I think that's the distinction when it comes to staffing is that, now we are helping manage risk for organizations because we are helping to prevent deterioration. We're hoping we can prevent admission. John and I've had many conversations about, in the ER that, that's your APC fee for service world, but once you're admitted, then you jump into DRG bundled payment reimbursement. You want to stay in fee for service. You want to treat and get out. You don't want that admission. So that's what that's going to start looking like or should start looking like for respiratory. Um, that's going to be our impact. So, if we've prevented a patient from going to the ICU, that that needs to be measured. That needs to be looked at. What did we do to prevent that? Because then, respiratory becomes like cybersecurity.
Yeah.
You know,
Yeah.
you
And
you've got to have cybersecurity regardless of whether or not there's a breach. You still have to have it.
Mhm.
So that's how our value is shown.
well, the other thing too is what was able to happen as a result of these outcomes. Carrie, you bring up a great point, right? You are there as risk prevention, right? But the other side is that how are we able to optimize these outcomes because of our involvement? Call a cardiothoracic surgeon and ask them how
Mhm.
excited they are to cancel their heart surgery or their elective heart procedure today because they don't have beds in the unit or they don't have beds on the floor. Go find an
Yeah.
orthopedic, ask the same question, right? These guys that are livid
Yeah.
because their surgeries, their elective procedures are being canceled because with bed capacity, these are also massive, massive financial opportunities for each and every day at the hospital. I mean, Hans, I know you and I both come from surgical center backgrounds or a large academic surgical center backgrounds where these procedures are invaluable to be able to perform. If you
Yep.
aren't able to do these types of procedures, that generate more overall revenue for the hospital. If a COPD patient gets admitted, that's about $8,000. But if a cardiothoracic procedure comes in, it's going to be an elective procedure that's covered. It's going to be about $75,000 to $80,000, right? Which one is going to raise more eyebrows from a C-suite level, right? The respiratory impact goes beyond respiratory care. It impacts the foundation of the hospital, their
Yep.
daily operations.
And I think this is where we are missing the ball. And I think this is where
Yes.
we as leaders, we as a body, the ARCG, like or local governing bodies, I think this is where we are missing the ball as to the value that we bring.
Yeah.
As to um, how we need to be part of the whole system. And one of the hospital I've worked with, what opened my mind is we were having issues with throughput. We're having issues with, by the time they come to the ED, they stay for that time, and when they get out the ICU, they're bottlenecking. So we had a whole 2 weeks of I think they brought a consulting in, and they brought all of us in a room. So now we start understanding how everybody plays a role into what's happening. Because now we still, as a culture, where we feel like the ICU therapist is more valuable than the floor therapist.
Mm-mm.
This is
Yep.
not new. So right now, even us trying to move into a value base as department, we are not even in unity to say, hey, we are here as a unit to make things better, where you feel like, in the ICUs, those are my elite therapists and this is why they need to be. And again, we still get get a badge of honor of managing the sickest patient, which is true. But again, what is the outcome? And we now downplaying the floor therapist who actually needs to either prevent a ICU admission or help them get through and help them exit. So it's a tough conversation. It's a tough balance.
Well, there's
And
always going to
go
be
ahead.
sick patients.
Hmm.
I mean, there's going to be traumas. There's going to be respiratory failure for reasons outside of, a pulmonary disease standpoint that are still going to require aggressive management and intervention. And so, but I feel like it's the context of the what's going on with the patient and ultimately the outcome. That floor therapist that just prevented a patient from coming to the ICU altogether is a win. That, critical care therapist that just reduced a ventilator day, that's a win. So there's room there across the board for everybody. All of those things matter.
Yeah,
Here's the
Carrie, it's one of the
curveball.
things. It's one of the things, Carrie. You and I've talked about COPD navigators. The hospitals, Hans, you bring up a good
Hmm.
point.
Yes.
Is that the mindset of, man, our elite RTs, our superhero RTs. Historically, you'll see is like, oh, it's the ICU people, right? But man, if you're able to sit here and be like, hey, that patient was definitely becoming decompensated on the floor, and then because of interventions, the RT was able to get a patient turned around and keep them on the floor, or more importantly, hey, that patient, our assembly line of ER to ICU to floor, it's like all of the assembly line structure disappears once they get to the floor. It becomes the Wild West. To enhance that
Yeah.
streamline to be continued, to maybe we now say, okay, now we've done great here, we've done great here. Now let's focus on how fast we can get this patient discharged, and at the same time keep them from coming back. Right. So that floor therapist actually is the most should be the most strategically thinking ones out there. And when we got the hospitals that you see that still have the COPD navigators roaming those hallways, those are hospitals that I'm saying, they're still seeing. They saw this coming, right? They saw this value base coming. And after COVID happened, I mean, a lot of those positions kind of went away and got absorbed into staffing, but you still have them. You still have them out there. And I see a lot of those ones having these very similar discussions that we're having here now.
Here's the question. Are we saying that volume base is bad, or are there hospital or locations in the city and the country well, volume based is still the way to go? Or are we saying that we need to have a mixture of volume and value? What are we saying? And we're gonna get
I
the
th-
next episode. We're gonna actually give them a little bit more tips. But right now, are we saying volume bad, value this is where it's at, or based on if it's a small rural hospital? What are we saying right now? Because I wanted to make sure after a leader actually listen to this podcast, they feel optimistic or they feel curious to now go research volume versus value. So what are we saying? Is volume completely outdated? Is bad and value is where it's at? Or should we have a mixture based on the hospital or based on your department location and the patient population that you are seeing?
No, I think this is that. I think what I want to hear people see out of this is it is a mix, but it's a respectable mix of seeing the and appreciating the balance. The balance is when it comes to volume, it is an RT driven protocol opportunity like I've never seen. This is where you supplement volume,
Yes.
meaning you're doing more treatments. Instead, you're doing more assessments. You're doing more evaluations. Your RTs are being brought in to consult and to observe and for their opinion to matter. And then from it, when it comes to the value, it's the outcome that's a result of that. Imagine a day when a respiratory therapist is called not to come do a treatment in the ER, but to evaluate and assess the need and the status of a new patient that shows up to the ER. That you're still having the same amount of volume if you come to what you're doing, but the outcome will be much more streamlined, much more efficient, and also more importantly driven by respiratory therapists. So I think that you bring up the most important question and the most important point about this is not allowing it to look like, oh, well, if you're doing less work, then that means you need less RTs. Not true. You have to supplement this vision with saying, no, if it was not for RTs, my RT driven protocols are not being done. Right? If our RT protocols are not being done, these outcomes that have gotten us these results won't happen. So I say substitute volume with busy work. Do away with busy work. Instead, bring work with purpose as a replacement.
Well, and I also think there's an opportunity with the electronic medical record
Oh
because,
yeah.
we collect a lot of data, but that data doesn't necessarily drive logic. And what we need to be asking at the end of the data collection that we're doing, what did we change? What is changing for this patient? That needs to be the question. And I think that our EMR documentation needs to start reflecting a more updated value based care approach. And I'm not seeing that currently.
Mm-hmm. Um, Here's the other question. How, trying to see how to ask that. What advice can we give the leader who's watching this right now on after we end this podcast within the next 30 days, 60 days, 90 days? How do we want somebody to digest this? What would be the next step? We're gonna come back and actually give tips on how to actually apply that. But from this conversation, what should somebody who's leading a respiratory department, what should they be doing in the next 30, 60, 90 days with this information of volume versus value-based care?
I would say they need to find out what goals are important to the organization that they are in.
Mm-hmm.
What they need to find out what problems are their organization trying to solve, and then start looking at how respiratory can help solve those issues. Um, this is not something obviously because, we have practiced this way in departments forever and ever and ever. So this is not something that we're going to be able to just flip a switch, obviously, and fix immediately.
Mm-hmm.
But I think one metric at a time. But I think it's going to have to start with people finding out, doing some homework. What are my issues, and how can my team help with those issues?
Mm-hmm. What you got, John?
My challenge would be to any leadership, RT, director, manager, go to your CFO, go to your CMOs, and ask them about what metric outcome would respiratory therapy could respiratory therapy contribute to in their metric performance. Have them answer the question for you, right? And this is a new
Yeah.
thing. It's a conversation that we have not been a part of from a executive C-suite
Nope.
standpoint, and have them answer the question for you, and then maybe challenge them with another question. So if respiratory disappeared, what metric would you think would be most impacted today at this hospital? We're never going to make a dent in this on our own. No one gets where they need to
No.
be without some help. We have to be invited to this
Absolutely.
table to essentially be more dominant in this conversation, because unfortunately, it's healthcare as a whole. Allied Health is not seeing what we are seeing, and that is, dude, respiratory care has an opportunity to absolutely smoke check this value based discussion. We are in a perfect spot. We take care of the most chronic of the hospital. We take care of all the burdensome patients, right? As we unfortunately refer to them as. I mean, I get it; they're there all the time, but the patients that bottleneck the hospital are in our wheelhouse. It's time for us to do something about it.
What do you hope or you wish our body of respiratory, I'm thinking about our national body of respiratory care, how do we approach this conversation? What do we need to do as a healthcare body to educate our leaders, to educate our therapists? Is there something that needs to be start being taught in school? How
Yeah,
do we start teaching that?
mindset, mindset
Well,
shift,
our
man.
job as leaders, yeah, and our job as leaders, I don't think that any respiratory therapist graduating comes out saying, I want to improve case mix index, or I want to reduce length of stay. They come out wanting to take care of patients. But our job as leaders is to connect those dots for the therapist, because, I hear a lot of people say, well, it's not, Carrie, it's not just business, it's patient care. But good patient care is good business. They are
Uh-huh.
connected. So I think that, for once in healthcare, you can have both things without having to sacrifice something. Right now, as it currently stands, we're always having to sacrifice something. And, whether that be staffing for volume or volume for staffing, like there's always something that somebody has to give up. But now there is seems to be more alignment, or alignment seems like it is a reachable goal. And so I think that that's what we need to do as leaders, is help the therapists at the bedside understand how all of those things play a part in good patient care. And when you have established yourself as being an influencer of good outcomes, then your conversations around resources become very, very different, because now you have made it clear that you are a big part of the treatment team.
Mm-hmm.
And, right now, as it currently stands, whenever you're looking at tasks are replaceable. Outcomes are not. That's different.
Say it again.
I said tasks are replaceable, outcomes are not. So that's the big takeaway. It's our time, guys. Time to shine. Like that. If there's ever been an opportunity for respiratory, I feel like it is now.
And I think that starts with
John,
changing the
what you got?
I think it starts with changing the definition of what shows success, right? And this is verbiage and how you talk within your own department. Stop focusing on nebulized treatments being delivered, treatments being done. One of the terms that used to always bother me at the bedside, especially when I was teaching the respiratory therapist, would be how many vent checks is you? I cannot stand the word that term vent checks. I'm like, check is that there's a ventilator in the room, or did you assess your ventilator patients? Right. We got to change a lot of little things, make big outcomes here. Right. So instead of focusing on
Yeah.
treatments and checks, if you will, instead focus on readmission preventions, focus on throughput improvement, focus on avoidable admissions impact, right? Focusing on outcomes achieved. How valuable were you at the bedside today, right? So, and our value as a society will increase when our conversations start being centered around our value.
Wow. It's been 45 minutes. We need to wrap it up, and also, I'm
Shoot,
I'm
man, we just
I'm
got this
letting
thing
everybody
going.
know there will be a part two.
Right.
No, that's why I was like, we need
Sounds
to
like
wrap.
I've had
Yeah,
enough.
but no, because one, it's a lot. We're probably gonna have maybe three parts to this conversation.
Yeah.
Because I'm gonna be very transparent. I've been in leadership for I would say a solid combined and true director and up, manager and up. I would say a solid 8 years. Um, and I went through it in the midst of COVID, and yet I never understood volume versus value base. I literally came to work every day and just kept trucking, like I was in the minefield. I was just mining, and not having the bigger picture in mind. So that means there's a lot of us leaders who actually also leading renowned departments, not just somebody in a 15 bed hospital and somewhere with two traffic lights. We actually have leaders in well renowned big massive flagship hospitals who do not grasp that mindset. And also, no matter how we do with engagement, how we do inside of it, the business aspect of it has to be strong. We need to know how to navigate those transition. So definitely, volume versus value base is a conversation that we need to have. We also will probably need to focus on part two, is to bring tips as to what creates value, what does value look like, and how does value affect staffing, affects engagement, reimbursement, and also, the other part is we need to have a conversation on how do we teach this as a body of professional. How does um, we want our organization to actually start having that conversation? Because many times we're talking about RVUs, how to make sure we create that, but it's so, I won't say outdated, but it's different. So we need to have a different conversation.
And I would
Well,
challenge.
I feel like we have an opportunity. Go ahead.
No, you're fine.
I was gonna say, I think we have an opportunity too to help, organizations absorb disruption. That was one of the biggest things during COVID. The organizations that were able to recover handled absorbing disruption better than others. That definitely matters. So we help prevent instability, we help them absorb disruption. That is huge from a
And you
strategic
think
standpoint.
so, Carrie? With that, you I'm glad you went first because this is a perfect segue. Was COVID-19 an example of was COVID-19 an example of volume-based or value-based care?
I mean, value-based care for me because the outcomes mattered.
Yeah.
But what
I
prevented
mean,
the outcomes from being overwhelmingly successful during COVID? Volume. Why did we
too
burn
much
staff out?
volume,
Right. So what I'm getting at here
too much volume.
is that COVID-19 is a great example of volume-based approach failing. Volume-based care has already demonstrated it
Yes,
will
in
fail your
real time.
healthcare system. It will fail you, it will fail your staff, it will
Absolutely.
burn you out, it will kill patients. And at the end of the day, it takes, instead of focusing on stop, think, assess, reevaluate, instead it's just keep my head above water trying to maintain, right? I'm trying to stay alive. And that's what COVID was. COVID was all of us drowning with just trying to get to the end of the darn shift, right? We all got hammered during COVID. And at the end of the day, no one can sit back and be like, man, during that really, really bad time of my life, my career, this country, we ever thought about what good, what did we learn good during that time? We just survived it.
Hmm.
That's all it was. It was a
Hmm.
just a we survived. That's the brand you got. I survived COVID-19, right? That is an example of
True.
volume
But the
based
outcomes were what mattered.
and they were horrible, right? And they were horrible. And they
Yeah.
were horrible because no one had the ability to stop, think, assess, analyze, and reevaluate. Because it is a perfect
Yep.
example of volume based healthcare failing utterly. And look, we've already done it. Let's not do it again. What systems do we have in
Mm-hmm.
place that value based healthcare can contribute to echo what Carrie, what you said at the start of this? How can we set up by having better throughput, better focusing on length of stay, better focusing on avoiding unnecessary admissions? How do we better prepare our hospitals for risk? And that's our contributor. That's how
Yep.
we contribute to everyday success, to where there's a mix between, yeah, we're busy, I'm volume, but also I'm quality, bringing value to the bedside. And I think that's the importance of saying we can respect the volume, but we got to really, really heavily lean in on the value and our impact of day to days at the bedside.
Yep.
I couldn't close any better, John. I couldn't close this any better. So for those of you watching this or listening to this, if you know a leader in healthcare, better yet, a respiratory leader, you need to send this podcast to them. Um, Definitely, we're gonna come back for part two, and maybe from part two we may decide to do a part three. But one thing that I know for sure, healthcare is changing,
Yep.
and the shift is not done. The episode before that with Dr. Yvonne Morante, and is that led us to this conversation. She literally mentioned that in the COVID-19 was a shift, but we are not done shifting. So right now it's time for us to, and you guys just mentioned it, we survived it. So we're still in survival mode.
But
So
we
right
didn't
now,
change anything.
so what we want you to
Yes.
do, leaders, one, it's in the next 30, 60, 90 days, educate yourself between volume and value based. Have conversation with your facility, with your organization. What drive metrics? What do you need to meet? And John definitely wants you to get a little bit spicy. He wants you to actually go and talk to your CMOs, CFOs, and ask them specific question. What metric do you hope respiratory is meeting? And if we are gone, what metric would lack? This is bold, but before you get there, educate yourself a little bit about volume
Yeah.
based and value based. But this was a great conversation. Definitely, we are coming back for part two with some tips on how to transition from volume to value, how to get a better mix, and definitely how to create value. One thing that I know, we tend to be siloed. We tend to be respiratory versus nurses, or respiratory versus radiology. We're supposed to be. We can't bring value on our own.
Nope.
You could actually help extubate the patient, but if if lab's not gonna get right, if everything else on the throughput and when it's time to discharge the patient is not right, we could get them out the ICU. They're gonna stay a few more days on the floors. And again, we need to start working together as a unit. John, thank you. We didn't tell them how we met. I think we met through Carrie because Carrie almost got me canceled. And then you enjoyed the conversation and you
Yeah.
reached out on and say, yo, man, I love what you do. We need to talk more about this. And definitely this conversation is needed. So I would say was needed because we're going to keep having it. We're going to have a part 2. Carrie, my friend, we go way back. You always say yes. We have more to talk about. We're definitely going to talk about a co-host conversation because you on this podcast a whole lot. Anything else I'm missing? Anything else y'all want to leave the people with before we say bye?
I don't think so. I mean, I feel like this was a great conversation, and I'm really excited for people to hear it. I hope that it's helpful, and I hope it sparks a lot more conversations.
Thank you. John?
I'm good, man. Thank you for the opportunity. I look forward to continue this episode too.
All right. Well, people, this was HR the Leader podcast, volume-based versus value-based. Come in the next few days for part 2. We'll see you soon.